So once again, I want to give make sure about what is a term of pasung, because pasung is in bahasa or in bahasa Indonesia or bahasa language. So pasung means a physical restraint or confinement of the mentally ill, but just only in the community, not in the institution. So all of the evaluation that we done based in the community. So we think that we cannot develop a better or a good evaluation system if we cannot understand about the problems a bit well. So we conduct research in 2008 and the last in 2011 that we published it, but actually the research is still ongoing until now, and we still collect a lot of data from other provinces in Indonesia. So pasung cases usually happen affected to male in productive age and having a schizophrenia as a chronic and relapsing disease, and they usually put in pasung because of the aggressive behavior, history of aggressive behavior. So I guess this will be very good and very important things to think if we want to unchain people with mental disorder. If we also can think about what kind of system that we need to be developed related with effect of or eliminating the aggressive behavior in people with mental illness. Duration of pasung is quite vary from days until years, but from the last research done by Prof. Minas in 2011, the average is around 4 years, and the frequency is more than one time. This is also related with the characteristic of relapsing disease. And we can imagine that if we put in chain in our hands or in our legs more than years, so this will be impact into the disabilities, not just only physical disabilities, but also mental, social, and occupational disabilities. So we also have to think about what kind of program that we need to develop related to this problem. Family as the initiator, this is the most data that we set from our data, our research data, and that's happened because of the negative perception about illness. Most of Indonesian people thinking that this is because of supernatural problems, but some of them feel shame because of their behavior, and then they also are thinking that negative perception is also coming about mental health care. You can imagine if our family member having a mental disorder and then treated by the mental health care, but having the side effect of the antipsychotic, so they will look very bad, and then they are thinking of that mental health care is opportunity for them to be better. They also thinking that mental hospital is not good in the quality of the services. For example, there's 2 cases from our research, from Rominas and myself, research that say that will be better for me or for the family to look after the patient in the home, because we will put them, or we will make them as a human compared to in mental hospital, who usually chain and then sometimes they didn't get any good treatment or nutrition. So we can see and understand that sometimes families see that pasung as a protection or therapy for the people with mental illness. The other data that showed is about access to care. This is a bit surprised because more than 78% of people with who put it in pasung ever have a experience to be in access to care, especially in mental hospital. So this will be a big question for us. Is that correct to bring the patient with or pasung patient or people in physical restraint to mental hospital? Is that can answer or solve all the problems related with that? That's the big question for us. And actually we get one of the answer of it, because by bringing the pasung patient to mental hospital, the family feel that they are lack of capacity to treat patient on the home, because they usually come just only 2 times. First when they are admit the patient to the hospital, and then the second when they pick up the patient for discharge. So for our opinion, our group opinion, pasung as a consequence of social, human rights, and mental health system problems. So by doing this kind of program, so this is like a door for better mental health system. But the next question is, what kind of mental health system need to be developed in eliminating this kind of practices? Our group from 3 provinces try to develop items based on mental health system elements. So in Melbourne 2012, we have a training facilitating by CIMH in 2012, and then we think that there is 8 items that maybe we can see or evaluate related with this program. First is about policy and regulation. We start our experience having an evaluation, look at the programs in national program. Actually, it's quite difficult for us to find a document of that national program except the national roadmap. But from this experience, having this first experience, we are really happy to see Dr. Dia's presentation related with future plan. We are thinking that it will be very important to have a policy and regulation related with Bebas Pasung or Free Pasung or other things, human rights violation related to people with mental illness. Even though Indonesia have been ratified a lot of documents, international documents related with human rights, so that's also a resource that we can use for the national roadmap. The second is about advocacy, consumer and family empowerment. This is not put it into the objective of the national roadmap until now, but I'm very happy, Dr. Dia, to see that in the future plan you also having a plan to increasing the role of consumer and family in our program. The third is about financing, is already mentioned with in national roadmap. The fourth is about intersectoral collaboration. These two, we realize positively that intersectoral collaboration is very important to eliminate these kind of practices. So increasing mental health knowledge of stakeholders and availability of multi-sectoral collaboration and coordination become the 2 main objectives also in the national roadmap. We didn't see exactly about the objective from the national roadmap related with human resources. But one more time, I'm very happy to see in the future plans that will be also including into the national roadmap related with human resource development. Mental health service infrastructure will be the next element. It's implementing human rights-based approach in treating people with mental disorder and providing quality mental health service in the community. I'm also very happy to see this objective, the last objective related to quality mental health service in the community, because this will be against the data that I already presented before, that mental hospital cannot solve all of the problems. The last is about monitoring and evaluation, which is the government say that this will be very important to implement a mental health efforts monitoring and evaluation for the Bebas Pasung program. So we try again to evaluate 2 other resources, because we know that the 18 from 34 provinces already conducted a Bebas Pasung program or Pasung Free program, and this has happened because of decentralization. But this is also like a portrait for us that there is no generic model of programs in Indonesia. But I guess that's never mind. We can learn from 3 provinces. We can try to find the power and the limitation of each province. So maybe also we can try to adopt it in our country or in another province for the future. So we conduct a study in 2012 in 3 provinces. Aceh was launched in 2009. Central Java launched the Free Pasung program in May 2011, and West Nusa Tenggara was launched in December 2011 about Free Pasung program. Data sources is coming from mental hospital and province health office, with the methods is in-depth interview, medical recording view, and secondary data which coming from several resources. So this is really a very good achievement related with these 3 provinces. If we are talking about Aceh, Aceh nearly getting more than 43% of the cases, Pasung cases, already eliminated through 3 years. And I guess we need to learn more from Central Java, which is on the second years, they can achieve more than 90%, nearly 100% of Pasung cases have been eliminated. So this is things that maybe we can learn how the way they can very productive and very active in doing this kind of program. West Nusa Tenggara start 1 year ago, and they achieve more than 20% of from the number of Pasung cases. So lesson learned that we can learn from each province is that 2 from 3 provinces has policy and regulation, even though the level of the regulation is not the same. For example, Aceh have a provincial regulation, but in Central Java, they just only have a governor regulation. The reason why it's very in the type of the regulation is because of the resources of for developing a regulation is quite different, because it's very expensive to have a provincial regulation, and it takes very long to develop provincial regulation. But we learned from Central Java that government regulation specific for Pasung can move all of the resources which is coming from other sectoral. So this is also an example that that government regulation can move the resources from the district and sub-district to eliminate these kind of practices. But for West Nusa Tenggara, there's not a regulation coming from the government, but this is like a mental hospital initiative. For the financing, all of the 3 provinces have their own financing, national or provincial or local funding. But we can see there's a lot of resources that we can learn from other provinces. For example, from Aceh, they have funding from NGO and community funds. But from Central Java, mental hospital budget was included into the programs. So they are mixed together between the provincial budget and mental hospital budget. So I guess this is also one of the type of collaboration that we can try to copy and then doing in other provinces. But in West Nusa Tenggara, they really depends on provincial budget only, not from the national, and also just only from mental hospital budget. So maybe we also have to think about how the way they can continue this program until several years. About intersectoral collaboration, 2 from 3 provinces have intersectoral mental health committee in every level. Every level is provincial and district and sub-district. But please don't think that intersectoral is very huge, even though we are starting just only related with Ministry of Health and Ministry of Social Affairs or Mental Health Office and Health Office and also Social Affairs Office. But this is one good things that we can see from as an intersectoral collaboration. About advocacy, consumer and family empowerment, there is 2 from 3 provinces have a very active consumer and family empowerment program. For example, in Aceh, they have a mental health cadre, and then as the consequence of mental health cadre is mental health alert village and mental health community forum, which is involving religious and community leader into that forum. In Central Java, even though this is still in ongoing process, but they have a plan to have a capacity building for community and then develop self-help group. For human resources, the 3 of this province have a human resources developmental plan. But from the things that we study in our case study, this human resource developmental plan is not a long-term human resource developmental plan, but just only a years, and then it really depends on the funding that they have. So this is also a lack that maybe we can try to solve, because we all together will be agree that human resources is very powerful component to eliminate these practices. In Aceh, we have a GP Plus, we have a community mental health nurse, and we have mental health cadres. But in other 2 provinces, they give a great emphasis to train GP. Related with mental health service and infrastructure, all of the three provinces has a very active outreach program and case finding program. But from the three provinces, just only Central Java has a very good and very, a structured pathway of care. This is can figure out the collaboration between primary healthcare, between primary healthcare, provincial health office, and mental hospital. So everybody who look this kind of pathway can understood well. If I found the case of Pasung, and then where do I have to go to inform the government or to inform the primary healthcare before they bring to mental hospital? Aceh focus on primary healthcare empowerment, but in our study, there's a lack of coordination with mental hospital. So usually, provincial or primary healthcare have a different gate with mental hospital. I give you one example. So if primary healthcare find the case, Pasung cases in the community, and mental hospital also do the same, and they never sharing the data related with it. So sometimes maybe Aceh found a lot of cases more than the data that I showed you, but the problem is because of the lack of the coordination and data information, so we cannot see the magnitude of the problems. The things that also coming from the Central Java is they are involving general hospital for comorbidity disease. But for West Nusa Tenggara, because this is really mental hospital initiative, all of the services based in the mental hospital. Actually, all of the cases patients bring to the hospital. This is the things that we learned, that there is no specific treatment for people for Pasung cases. So, for example, that there is no rehabilitation program in the hospital. Except in Aceh, they usually conduct that in community. And for acute treatment, there is no acute treatment in primary healthcare. So acute treatment just only coming from mental hospital. The last is about treatment discrepancies. So the medication from mental hospital is quite different with medication in primary healthcare. So if the patient back to the community, they cannot get further medication because they have a different medication. And then, so that's why the people who are discharged from the hospital usually come back again to the hospital. So this is not solving one of the problems of the Pasung, because they are very, very difficult to access for the mental health. For monitoring and evaluation for these three provinces, there is no monitoring and evaluation system except from primary healthcare report. So, or the hospital report. So there is no integrated reporting system in three provinces. So based on all of our lessons learned, this is things that maybe can we develop for the next phase. First is evaluation needs a better information system, especially about the database. Would be good if the government can develop a national database with one ID, because like you hear before that usually people put in Pasung more than one. So we can imagine if they didn't put in one ID, so one patient can be counted into more than one patient. And the second is focus, our evaluation just recently just only focus on output. So we can present in front of you about the number of cases, about the input evaluation and the process evaluation. But we are very sorry that we still cannot give you the result of the outcome. For example, about how the program can improving the knowledge and skill of the community to doing care or doing treatment in the community. We also cannot see yet about the better attitude toward the people with mental illness. We also cannot see yet about disability limitation, about quality of life related with Pasung cases who already been treated in the community or in the hospital. The last, we also cannot see the sustainability of the support from each of the sectors. So actually our homework is still very huge and very long, but we are very happy to discuss about this with you, and also we present back again to you after several years. We also think that evaluation not just only about medical or medical context, but also need to including social and human right context. And the last but not least, issues about sustainability of the program. One more time, sometimes Pasung looks as a project rather than program. So we usually think about we will start it in 2010, and then we will be finished in 2014, which I already mentioned to you that doing something in Pasung cases means developing mental health system development. That's all for my presentation. Thank you very much for your attention.